All right, welcome everyone to Sisters in Red Heart Health at Every Age. We are letting people come in from the waiting room and we will kick things off shortly. I'm happy to see everybody here on a Sunday afternoon, so thank you for spending your day with us. We hope to give you a lot of wonderful information. A couple of housekeeping issues. We are currently on Zoom. We are also live streaming on Facebook as well as YouTube. For those of you who are in the Zoom, you can put your questions into the Q&A, and we will have an opportunity for you to engage with our panelists and to have your questions answered. For those of you who are on Facebook or YouTube, feel free to leave a comment there, and we will have chapter members who will go into the chat and they will then bring your questions to the Zoom so that they can also be addressed in real time. All right, I think we have gotten to a stable number of people being let in from the waiting room. So I will go ahead and kick things off. My name is Dr. Cherie Hill. I am a member of the Atlanta Suburban Alumni Chapter of Delta Sigma Theta Sorority Incorporated. And I will go ahead and introduce you all to Sisters in Red, Heart Health at Every Age. We do have several sponsors who have coordinated this event, and I'd like to first start out and allow them to come off mute and just say a brief word to our audience. So we'll first start with our representative from the American Heart Association. I believe that is Jasmine Martinez. All right. Well, thank you to the American Heart Association. Next, we have our representative from NCNW, which is the National Council of Negro Women, the Greater Atlanta section. And I believe we have Angela here. I see Angelia Brown. Can we raise her to panelist so that she may be able to come off mute? While we're waiting for her to come off mute, we also have our representatives from Grady. So we have Dr. Yolanda Wimberly, who is our physical and mental health chair. She's actually representing us at Delta Days at the Capitol on behalf of our region. We also have our panelist, our second panelist, who is also from Grady. So you will hear from her shortly. Obviously, Atlanta Suburban Alumni Chapter, our chapter president, Soror Tama Trammell, is also at the Capitol and sends her regards. And then lastly, we have Xi Alpha Deltas, which are from Georgia Tech. And I believe that we have Maya on, and we may have everybody come off mute at the end, since it looks like we're having a little difficulty with everybody being able to speak. So one of the things that hopefully you all have seen is that February is American Heart Month, and this is a time where we want to make sure that women are aware of their cardiac status. Unfortunately, heart disease is still a big source of mortality in the United States, particularly for Black women. And we know that as women who are experiencing pregnancy, this can be an early place where you may see heart disease manifest. And then certainly throughout the life continuum, as we transition from reproductive years into our menopausal years, we unfortunately may see even higher rates of heart disease. So we do have an engaging panel today. I will go ahead and introduce our panelists, and then we also have a patient experience that you will also get to hear a little bit more about. So, starting from the beginning, we will have Dr. Kawita Phillips, who will be joining us from Morehouse School of Medicine. And Dr. Phillips is a highly accomplished OBGYN who is here in Atlanta, Georgia, with more than 15 years of clinical and academic experience. She's a native of Albany, Georgia, where she graduated from FAMU, so I'm sure she sees plenty of her chapter sorors here. She also went on to matriculate at Harvard Medical School, where she received her MD in 2006. She then went on to complete her residency training at Morehouse School of Medicine in 2010, where she currently serves as an associate professor and the residency program director. In this role, she is very dedicated to education and mentorship, training of future physicians. She is also taking care of the patients in Atlanta, including at Grady, Emory University Hospital Midtown, Wellstar, Piedmont. She's all over. And she is a lifetime member of our illustrious sorority, Delta Sigma Theta Sorority Incorporated. So we will hear from Dr. Phillips shortly. Next up, we have Dr. Ijama Eliazu, who's an Emory cardiologist and director of Cardio-Obstetrics Initiative at Grady Hospital. She is leading efforts to redefine heart health for women across generations. Her vision centers on closing the divide between obstetrics and cardiovascular care, creating pathways for prevention, equity, and long-term wellness for women at every life stage. And then lastly, but certainly not least, Dr. Janella Burse, who is an ASAC member as well. She has been practicing in Atlanta, Georgia since 1977 and is board certified as one of the founding partners for Better Health Greater Life LLC, a practice that focuses not only on women's health, but promotes a holistic journey of health for everyone. She has spent most of her career in community medicine, serving the greater metro Atlanta area, and she has also served on faculty at the Philadelphia College of Osteopathic Medicine. She believes in reaching back to mentor medical students and believes that it's never a one-way street. She learns from her students as much as she teaches. She also was proudly honored by the Atlanta Medical Association in 2025 as Physician of the Year. She also has a BS from University of Georgia with a degree in genetics. She received her doctorate from Morehouse School of Medicine and then completed her residency training at Wayne State in Detroit. She is married and has 3 children, and as I mentioned, she is a proud member of Delta Sigma Theta Sorority Incorporated right here in our own chapter. So, next, I would like to turn it over to Nicole, affectionately known as Nikki Ellis, to tell us a little bit about her story.
I'm here.
All right, we'll let you kick it off. Tell us a
All
little bit
right.
about
Well,
your
thank you so
story.
much for inviting me again. My name is Nicole Ellis, and I'm really excited to tell my story. Last summer, I had chest pain. I was at work, I had chest pain, and decided to go home. Got home, and my husband said I just didn't look right, and he urged me to go to urgent care. So he took me over to urgent care. And when I got there, they took me back immediately. They took me back, they did my EKG, and it came back that it was abnormal. They urged me to go over to the ER right away. So I went over to Fayette, Piedmont. And when I got there, I can tell you I hadn't seen a crowd like that since COVID. It was so crowded. It was just people in pain everywhere, and I just didn't want to be there. And I wanted to leave, but my husband was like, "No, you're going to stay." It was so crowded when I got there that they couldn't see me right away. So they took my temperature, my blood pressure, all my vitals every hour on the hour. I was literally there for 10 hours. During that time, they actually did some testing, but everything came back normal. And before I left, I spoke with the doctor and I said, listen, I had tightness in my chest. I had, it wasn't sharp pain, it was kind of a tightness and a pressure that I was having in my chest. And I said, pain doesn't come from just anywhere. And he said, well, nothing, we didn't see anything. If you want to see a cardiologist, you can see a cardiologist. So I made the appointment. I did follow up because I just didn't feel right just saying that everything was okay. I made an appointment. I was able to get in right away. And the cardiologist stated that because of my family history, that he'll go ahead and do some further testing. And he did a CT calcium score test. And when the results came back, he said, you actually do have a blockage. I can't really see how much blockage you have, but you have a blockage. So I want to do some further testing. So he set me up with a heart surgeon to do I believe it's in, the doctors on here can correct me. I believe it was a coronary angiogram that I had done where they were going to put some dye in my system to look at my arteries to see what type of blockage that I had. And he said, to be honest, Miss Ellis, if there's a blockage, I'm going to clear it right away. I'm not going to wake you up to give you, to discuss what your options are. We're going to go ahead and clear it. And if we need to, if we find a severe blockage, we're going to go ahead and put a stent in. And I remember sitting in pre-op with my husband, and he was so emotional. He was just tearing up while I was laying there, the IV. They had started the IV drip. And I remember at the time, we were building our house, and we're in our house now, but we were building our house. And I just looked up at him. I said, I don't know what's going to happen, but if this doesn't come out well, I really just want you to go ahead and build that house. And I just remember that was my last thoughts before I was wheeled into the operating room. Went into the operating room and started counting back and fell asleep, of course. And then when I woke up and I was able to get my bearings, the doctor said he wanted to talk to me about what had taken place. So he said once he got in there, they did find a severe blockage. He said that one of my arteries was 10% blocked, one was 20% blocked, and my third artery was 90% blocked. And it took me a second for that to sink in because when I heard 90% block, I knew at that moment that that could have taken me out at any moment, having a 90% blockage. I went back to see my cardiologist to go over all my results. And he said, well, as I said, you have heart disease on both sides of your family. And I said, well, I never thought about heart disease for me because I know that my dad smoked from the time that he was 11 until he died. And my mom, she used to smoke, but she also ate everything from the rooter to the tutor on a pork, on a pig. So I never looked at the family history as actually family history because there were so many external factors. It was at that moment that I think everything kind of changed in my life. I had a lot of fear. And I had to start to get over that because I could not let it consume me because it was starting to consume me. And one thing I know is that fear can either freeze you or it can focus you. I was afraid of all the stats that was coming back. I was afraid of the what ifs. I was afraid of what I couldn't control. But slowly, I started to turn that fear into intentionality. I became very protective of my peace, more serious about my stress, more committed about managing my health, more willing to say no, more willing to rest. Because one thing that I did learn through this process is that your body whispers before it screams. And I had been ignoring the whispers. Here's what I know. I have a 90% blockage. I could have ignored the pressure. I could have left that ER, but I didn't because someone noticed that I didn't look right. And I had to listen to my husband when he pushed me to do that. Once I got that diagnosis, one thing that I can tell you is I started to share my story on Facebook. And I got a lot of people reaching out to me on social media, people that I knew, people that I didn't know. And one thing that was clear is that they wanted to know what I did to cause this. And I started internalizing that because I felt like I was being blamed for this disease that I had no control over. Or I felt like I had no control over. But I realized that they weren't trying to blame me. They were just trying to figure out how what they could do to kind of avoid this happening to them. And so I embraced it. I started blogging and talking about it and answering all the blogs and just asking people to just go get tested. One thing it did is it awakened how precious life is. It awakened how fragile we really are. And one thing I learned is that I couldn't outwork biology. I couldn't out achieve my arteries, and I couldn't out hustle heart disease because everybody that knows me knows that I was either at work, I was always volunteering, I was on this board, on that board, and I didn't really have a lot of downtime. And we have a habit of celebrating grind culture. We have a habit of applauding exhaustion. We normalize stress. But one thing I know is that my heart was keeping score. And my score at this point was 90% of blockage that I had to face and deal with. So today, I'm standing here not as a victim of heart disease, but as someone that chose to listen to my body despite them telling me that everything was okay. I advocated for myself. I chose to fight, and I'm choosing to change, and I'm still standing here. One thing I can tell you is that mortality has moved from the back of my brain to the forefront of my mind. My heart is on my brain every single day. It is not something that I can ignore. So I'm hypersensitive to every feeling in my chest, every flutter in my chest, every pain in my chest, every tightness that I feel. I am always thinking about my heart. So one thing I want my story to do for you, if it doesn't do anything, I want it to interrupt your patterns. That appointment that you need to make it. Get your cholesterol checked, get your mammograms, get everything that you need to do, and stop ignoring all those flutterings, all those twinges, all those feelings that you've been putting off and passing off. I hope that this interrupts the pattern for you to take some rest and to breathe because the most important meeting that you're ever going to attend is the one with your own body right now. And that is the most valuable asset that you own is that heart beating in your chest because I know that we think we have to be there for everybody else. But if we can't be there for ourselves, what good are we going to be if we're even here for the people in our lives? Every beat in my heart right now is a gift, and I don't take it for granted anymore. My heart is fighting for me. My heart wants to fight for you. And the last question I have is, will you fight for it? Go get tested. Thank you.
Thank you so much. I'm trying not to cry over here. That was deeply personable, and I think really each of us could resonate with some part of that story. I loved the phrase that fear can either freeze you or focus you. And thank you for just taking this time to share with us how it really focused you. And you're using your voice to share with so many women in our community here. And I see some thank yous in the chat. I do see one question that said, what were some of your whispers or signs of heart disease? Now that you know where you ended up, what were the things that were whispering in advance that maybe you could have listened to differently?
Yes, there were a few signs. I was tired. I was more tired than normal. But more than anything, I was putting off all of the tightness in my chest for acid reflux. I was saying it was acid reflux, and I was taking anything to get rid of acid reflux every single night, which would seem to take it away. But I was ignoring true signs of the tightness in my chest and not getting checked right away.
And I think that's a great point because I do think oftentimes, your stomach is over here in the top left, your heart is over there too, and so there can be some overlap between that kind of dyspepsia or reflux disease that is a little bit more acceptable, right? Than to think something is going on with your heart. So thank you. That's definitely something. It's a good take home point. The second question that popped up is how has your diet changed? I know you talked a little bit about kind of pork intake and smoking. What are some adjustments that you made based on what you saw in your family and then in your own personal life?
Yes, one thing that I was, it's been a lot that I have changed. I don't eat a lot of pork anymore. Not that I was a huge pork, but I did enjoy, going out for brunch and having bacon with it. So I'm very cognizant of pork products that I'm putting in my body. Also, I've reduced beef, and when I do eat beef, I make sure it's lean and it's grass fed. I'm cognizant of my water intake because I know that I was not the best at getting enough fluids in my system every single day. So I am more cognizant of that. I've reduced caffeine because I would drink caffeine throughout the day. I've limited down to 1 cup of coffee. Um, I Even social drinking, I mean, I may have a drink, but that's it. It's just, I just don't feel right doing a lot of things that I used to do. Um, so I'll have one drink, but that's it. And I won't allow myself to have more than 1 cup of coffee a day. And if I have a cup of coffee, I won't have any other caffeine products.
Awesome. Well, it sounds like you have learned some great tools that you are carrying forward, and thank you so much for sharing your story. We are going to move on to some of our slides, and then certainly at the end, we'll have the opportunity for you to answer any additional questions. All right, so first up, we have Dr. Kawita Phillips.
All right, good afternoon, everyone. I'm so happy to have been asked to be here. I'm a member of Marietta Roswell, certainly happy to be here with our ASAC SOARs. And also for Nikki's testimony, because, as someone who's in this perimenopause that I'm going to speak with you a little bit about now, I think that even though we are physicians, that you'll hear from, we experience many of the same things. We forget to get our mammograms or we get too busy to get them. We are not paying as much attention to our bodies as we should either. And so I'm hopeful that with some of this information that we're able to kind of share, that it will spur some of you to go and see your gynecologist, go to see your cardiologist and your primary care doctors, and maybe take care of some of those things that have been nagging you. But because we're talking about menopause, I thought it would be apropos to talk a little bit about perimenopause, partly because I see us all talking about it online. And again, I'm in that range. And so I'm seeing a lot of that in my algorithm. And just want to acknowledge that a lot of what we are seeing and feeling are real. They are real symptoms for us as we get closer to menopause. So perimenopause, what is it? It's essentially it's a natural stage of changes that we all experience. You remember that there was a time where you didn't have a cycle, you started having a cycle, we call that menarche, and then you go into kind of your reproductive years. And that perimenopausal phase is really that phase that's between kind of our what we consider kind of our normal menopause, normal cycles to that time where they become a little bit more abnormal and our hormones change a little bit. So we definitely have a shift in our hormone levels, and that can be variable. So oftentimes, what I get as a physician hearing this is people want to get their hormones checked, and that's great. But because they can be so variable, I think it's important for us to just make sure you understand they change. But what's normal for you might not be what's normal for someone else. Our periods, they become less predictable. So whereas we might have been having cycles every 28 days, every 31 days, maybe we're having, some of us will have that experience where they're coming every 14 days for a year, and then they don't come but every 45 days. And that's really our body just telling us that we don't have the normal kind of eggs that we used to have in those ovaries. They're not giving the same signals to the body. And so we're getting closer to that time where we're no longer going to have cycles. On average, this time can be about 4 years, but I'm going to tell you that the symptoms that we experience, and you can stay there for me, please, Cherie. The symptoms that we experience can be anywhere from that 4 year mark to 12 years. And we know that we see different and sometimes longer symptoms in perimenopause for women that are of African descent. So your hormones will fluctuate. Your estrogen levels absolutely change. Many of us will experience sleep disturbances. That might be that we can't fall asleep, or it might be that we just can't stay asleep. So we'll see different kinds of iterations of that. Our mood changes. You might experience more depression, more anxiety. We might see some skin changes. Everything just kind of feels more brittle, more dry than what we've actually had. Certainly, as a gynecologist, I'm oftentimes speaking to women about the changes that they see on their vulva, so the outside kind of external area, what they're experiencing with vaginal dryness. Maybe the vaginal canal gets a little bit narrower, so the experience of intimacy might feel differently. Some women will also have different changes around sex as well as with incontinence. And certainly, I think most of us can really attest to those menstrual cycles changing. And like I said, they can change and be shorter, or they might change and be a little bit longer, maybe even heavier. And then the kind of the classic sign that many of us will experience are those hot flashes. You immediately get hot. Um, the experience that I remember watching my mother have was, I need to go outside, or I need to take these clothes off right now. And so, we know that that is partly what people are experiencing. Night sweats, right? You wake up, everything is soaked. And that is almost always secondary to just those hormonal changes that are occurring. I'll take the next slide, please. So in terms of our menstrual cycles, they just look different. They might be longer, they might be heavier, they might be shorter. I will say that for me, I'm happy when my cycle is skipping. I'm ready for menopause to occur, but that might not be everybody's feeling about it. But certainly, you might start skipping some cycles. I'll take the next slide, please. So when should you talk? Talk to the clinicians, talk to your gynecologist or your family nurse practitioner or your internal medicine doctor. Talk to all of us early. Talk to us, the gynecologist, when that bleeding cycle changes, when it gets heavier. Talk to us, because some people are kind of suffering for years with some of these symptoms that they know will eventually go away, but you don't have to suffer. Talk to us. Talk to us when those periods get lighter, when those symptoms start disrupting your life. But in general, if you're looking for the gynecologist, you can talk to us anytime about any of these symptoms. We might not always be able to fix it, but we'll oftentimes have some remedies that will be helpful for you. And so as you go into that perimenopausal phase and you go into menopause, you are not alone. We really would like to help you where we can. Thank you.
Thank you so much for sharing some of your own personal anecdotes and really giving us the basic nuts and bolts about perimenopause. We have a first question here in the chat. Are there any additional natural remedies to assist with prevention?
So I assume when you talk about prevention, or that you're talking about prevention of some of the normal kind of maybe hormonal fluctuations that we see. In terms of like natural things, I will tell you that there are not great natural remedies that we have good scientific evidence about. Now, that does not mean that we don't see them work for some people. I think that certainly some people will have good experience with some of the natural, like phytoestrogens that you can find in both supplements as well as in certain foods. They might, get a benefit from there. I have seen different herbal remedies that some people will swear by as helping them, but I think that it's going to be trial and error for you. And I think that you need to be kind of prepared to know that you might try something, it might not work well for you, and you can always try something else. Hopefully that answered your question.
Thank you. I think it's a good segue into our next question, which is first, thank you for being here. And one of our audience members would love for you to speak a little bit about your opinion of incorporating HRT during menopause.
Right. So HRT, it kind of got a bad rap. I remember as a medical student in the early 2000s, and the women's heart study was kind of coming out, and we were talking about it as students. And so it's something that I had a little bit of range with, and it kind of made us scared. And a lot of people really backed off. If you looked at the way that we kind of handled HRT, 20 years ago, a lot of it was many people were not, it wasn't being recommended. But I think that as we have looked into that evidence more, kind of understood more of the nuances and where the studies failed us a little bit, I think HRT is a great option for people. The way that I tell my patients that we should think about it is we want a dose that's going to be the lowest dose that's going to be effective for you. And so for many of us, the way that we'll start your HRT or your hormone replacement therapy, which is what that stands for, we will usually start you with a low dose, give you a couple of months of that dose, and then escalate your dose over time so that we can figure out what's going to work for you. And you can get your HRT in different ways. A patch. You might be someone who does not do great with a patch and would do better with a vaginal cream. You might be someone who does well with a pill, and so it can come in different iterations. And I think you should just talk to someone and kind of figure out what you all are happy with, and then start something. See if it's giving you the benefits that you're looking for, and then escalate the dose if needed.
Yes, I think that is great advice. I think we have maybe time for two more questions, and then we will move on to the next portion of our slides. So I think we could potentially combine these two. Can you talk a little bit more about kind of like that average age of menopause and perimenopause? Someone is inquiring if you can start to experience those things in your mid 30s. And then what is that kind of average number of years for perimenopause? Is it just losing your cycle that shows that you're in menopause? What are the things that we should be looking for?
So the average age of menopause in the US is 51.2, so around 51 years old. But that means whenever you're talking to a physician or a scientist, I mean, we're looking at bell curves. So there are people who are going to be on the lower end of that spectrum. So you might see someone who doesn't have a cycle at 47, and that would not necessarily be abnormal. If they're under 40, we do consider that abnormal. Um, and then you might see people who are 55, 56 who are still having their cycles, but the average age is about 51. In terms of perimenopause, all the data that I could find, it says 4 years is about average. So if you take the 4 minus the 51, about 47 to about 51. We really say menopause is when you have not had a cycle for 12 months. So if you are in a situation like me where you might be having a cycle, some months you might have it every month, and then there might be 3 or 4 months in between. You are not menopausal. You are still in perimenopause. So while I was getting excited, don't get too excited too fast. You need those 12 months of not having a cycle before we call you menopause. But there is quite good evidence that women who are smokers have symptoms that tend to be a little bit more aggressive. We also see that in African American women as well, just longer symptoms. And so you might be experiencing some of that in your 30s as well. So yes.
Yeah, I think that's a great point. And, if you are in your 30s and then you do go 12 months without a period, it's definitely worth mentioning that to your physician. There are other symptoms or other conditions that can take away your periods, namely pregnancy, but also polycystic ovarian syndrome. Sometimes it is premature ovarian failure. And certainly make sure that you're keeping a diary of your menstrual habits and other associated symptoms so that you can discuss that with your physician. We're going to go ahead and move on in our slides, but we will certainly have an opportunity for more questions in a moment here. So next up, we have Dr. Ajama Eliazu, who is going to be speaking to us from the cardiology perspective.
Awesome. Thank you so much. Another quick thank you to my colleagues in the OBGYN space for inviting me to this, and to everyone who has sponsored this event, and to everyone who's here. We cannot have these conversations in a silo. And so I'm so grateful to be able to bring the cardiology perspective here to kind of shine and put a spotlight on heart health from a cardiology perspective. So I just want to kind of touch base on a few of the risk factors that we know exist, but specifically for women. We always kind of talk about the traditional risk factors, right? We talk about diabetes and smoking, obesity, sedentary behavior, or, sort of not getting enough physical activity as risk factors for cardiovascular disease. High cholesterol, all of these things, of course, do play a factor in lifetime risk of cardiovascular disease, but that's not all that is there. We talk about family history, but as Nikki mentioned, that's not all that's there, and that's not all that matters. We're starting to learn more about these emerging risk factors, so to speak. So these novel risk factors that may play a part in whether or not a woman develops cardiovascular disease later on in her lifetime. And some of these I will highlight and kind of talk a little bit about as the presentation moves forward, but some of these have to do with pregnancy itself. So we're learning so much more about hypertension in pregnancy and how that sort of plays a role into future risk of heart disease. We'll talk about that a little bit. Gestational diabetes is another big one that predisposes you to regular diabetes or just diabetes mellitus, DM, and that has a 59 higher risk of having a myocardial infarction or a heart attack. Early menopause we'll talk about, and I know the conversation has already started on that, but that increases risk of heart disease, particularly due to the hormonal changes and how that can impact some of the traditional risk factors. And then depression. So I just published a paper not too long ago in the American Heart Association Journal, and we looked at the impact of stress, so perceived stress, and how that affects how an individual goes on to live their life and develop cardiovascular disease. And so we saw that these individuals with higher stress levels had lower activity levels, they had increase in their lipids, they had poor management of their blood sugar levels. All these things went on to predispose them to heart disease. We saw this preferentially in younger patients. We saw this in women. We saw this in people of color. So I preach this all the time to my patients about stress management as a therapeutic agent. I talk to them, how can we get your stress levels down? Because we now know that that does impact future cardiovascular disease risk. Next slide. So I mentioned a little bit about pregnancy. So why does maternal health sort of matter in this cardiovascular disease discussion? It matters so much. When you look at this slide, and I know there's a lot on there, so I'm going to try to break it down. I want you to sort of take away the fact that women, especially Black women, are going into pregnancy with more risk factors. We are not as healthy as we used to be. There's older patients going into pregnancy, getting pregnant older. And so patients are coming in with higher risk factors. And we know that these risk factors predispose them to adverse pregnancy outcomes. So if you have hypertension, if you have obesity, if your lipids are out of whack or your insulin is out of whack, you come into pregnancy being more at risk of having adverse pregnancy outcomes, such as hypertensive disorders of pregnancy, such as gestational diabetes, such as small for gestational age infants. And when you have these adverse pregnancy outcomes, it not only impacts your intra-pregnancy risk, but so the risk during the actual pregnancy, it impacts your inter-pregnancy risk. So after hopefully you complete a successful pregnancy, you now have an increased risk of both cardiovascular disease and a further APO development or adverse pregnancy outcome development if you ever choose to get pregnant again. And so you can see that this cycle kind of propagates itself. If patients are entering subsequent pregnancies with more CV risk, they have more adverse pregnancy outcomes, more adverse pregnancy outcomes then leads you to more increased cardiovascular disease risk, and so on and so forth. And so this is why the conversation around, what pregnancy looks like for each individual is so important. Next slide. So just a spotlight on hypertensive disorders of pregnancy. This is the most common one. So preeclampsia is the leading cause of severe maternal morbidity, and adverse pregnancy outcomes as a whole sort of encompass 20% of pregnancies and or affect 20% of pregnancies annually, but hypertensive disorders are by far the most common. And so we talk about hypertensive disorders of pregnancy, we're looking at a 3.7 times risk of developing hypertension, after your pregnancy. So even though in some women we'll see the blood pressure normalize after pregnancy, in a few years, they have a hypertensive disorder, and they're right back in my office or in their primary care office. We see an increased risk of stroke. We see an increased risk of arrhythmia. We see a 4-time risk of heart failure. And all of this kind of increases your all-cause death. This is why it's so important for us to know our history, to not kind of pocket that, oh, I had preeclampsia or I had gestational diabetes during my pregnancy, and put that in your back pocket and leave it alone, but to mention that when you're at your doctor's visits, because it does affect future cardiovascular disease risk. And sometimes when you're at your PCP office and you're having some of these symptoms, knowing this background may be the key that allows them to kind of plug you into cardiovascular care. Next slide. So a little bit on menopause. It's such a big topic, and something that we should certainly talk about when we look at it through the cardiovascular disease lens. The average age of menopause is 51. That's already been mentioned. But this perimenopause period can last a few years, typically ages 45 to 55, but that's, as has already been mentioned, it's a bell curve, and so some people are different. One thing to kind of note is that during this period, a lot of different physiological changes happen. So you have changes in blood pressure, the arteries become stiffer, blood pressure often rises. You have changes in lipids or in cholesterol. There is an increase in the bad cholesterol and decrease in sort of the good cholesterol. And a lot of that has to do with estrogen and estrogen's role in affecting some of these cholesterol levels. We have an increase in sort of fat distribution. And so there tends to be more distribution of fat in the belly area, which can be more inflammatory and can affect future cardiovascular disease risk. And then, we have patients who undergo this earlier in life. So we talked about premature menopause. And so, before age 40 is considered premature, and before age 45, around there, it's considered sort of early. And those patients we know have a significantly higher risk of ischemic heart disease just because of those changes that I mentioned that occurred. So how do we think about menopausal hormonal therapy from a cardiovascular disease pregnancy? I love this kind of illustration. This was taken from a JACC, Journal of American College of Cardiology, published by one of our Emory cardiologists, Dr. Wenger, who it just turned 95 this year. So she is really such a trailblazer in the field, and she's still working at Grady. God bless her. But this slide was taken from, one of their most popular papers, and it shows this sort of traffic light approach. So when do we give the green light? We absolutely give the green light for patients who have had recent menopause. So the kind of 10-year rule, which is that there's a window of opportunity before age 60, and sort of usually in that 10-year range of a patient having had menopause. And that's when we would like to start the hormonal therapy for all the benefits that it has, in terms of the symptoms and the bone health and all the things that it can do. And so anytime we see that we're in this green light area, we absolutely give, our thumbs up to start menopausal hormonal therapy. Where we start to sweat a little bit as cardiologists is when we see that patients have some of these traditional risk factors. So they're diabetic, they're smokers, maybe their blood pressure is uncontrolled, they're not moving around a lot. We have a calculator that we use quite often called a ASCVD risk calculator. And that calculator sort of tells us what the lifetime risk of atherosclerotic cardiovascular disease is. And if that risk is between 5 to 10, we pause a bit and see if we can mitigate some of these risk factors or, kind of get you to a more healthier profile. Or we think about, can we do menopausal hormonotherapy, but maybe a transdermal approach or an approach that's not oral, just to kind of decrease some of these risk factors. Okay. And then sorry, just one more slide, go back. Oh, right there. So, and then the red light individuals, we really try not to start menopausal hormonotherapy in these patients. And these are people with known coronary artery disease or who have had events. These are people who have had strokes, who have had breast cancer, because we know that the hormone, if we give back some of these hormones, that can kind of increase those cancer cells growth. And so we try to watch out for that. And then patients who, like I mentioned, that calculator risk is greater than 10%. And it's a risk benefit discussion in every single individual. And it's a conversation that you should have with your physician, with your cardiologist. But it's really important to think about it in this kind of stoplight approach, because it's most favorable for people who are healthy, like I said, and it's not a preventative strategy, as I think has been kind of highlighted more recently in the media. So, last slide. Taking control across the lifespan. Advocacy really starts with you. I so appreciated Nikki's story because so many things came up for me that was really pertinent, that I've heard multiple times by my patients, telling me that, they wish they would have, And a lot of that is about self-care, right? So prioritize yourself, prioritize your nutrition. As cardiologists, we talk a lot about the Mediterranean diet as being one of the most healthiest diet, and the one that's been most published on. And so that includes a lot of veggies, a lot of legumes, using olive oil instead of, regular sort of canola oil, vegetable oil, eating a lot of lean protein, much more fish, and food items that are low in sodium. We talk about increasing your activity levels. So aiming for 150 minutes of moderate to vigorous intensity exercise. So moderate to vigorous intensity, what does that mean? It means that you can't have a conversation with me while you're doing your exercise. So if you're chatting with me and you're having a conversation and you have full breath, then you're not moderate to vigorous. So you got to step it up a little bit there, and aiming for 150 minutes, because that's sort of the cutoff that we've seen in the literature that really affects long-term cardiovascular disease risk. Of course, quitting tobacco. Cigarettes are my arch nemesis as a cardiologist. Just so much inflammatory risk there. And the smoking risk effect on coronary artery disease is 25% higher for women than it is for men. So quitting smoking becomes much more important for us than it is for our male counterparts. Sleep is so important. It regulates your hormones. It regulates your blood pressure. As I mentioned before, I'm a big advocate on reducing stress, and sleep is a huge part of that. So increasing your sleep hygiene and just making sure that you're prioritizing good, healthy sleep. And then managing weight. So we've all sort of heard about some of these GLP-1 RAs. This is your Ozempic. This is your Mounjaro. These are the medications that can help sort of with weight loss, in addition to helping insulin sensitivity and, those with a diabetic or pre-diabetic profile. People are getting on these more, and there's still regulations about who can, insurance can cover these medications for, but you can also get them safely and FDA approved through, some other websites that are out in the media right now. And then, as I mentioned, share your pregnancy and hormonal history with your cardiologist. It's so important for us to know, okay, I had preeclampsia in every single pregnancy. I had preeclampsia in the first pregnancy, and then the second pregnancy, I had preeclampsia and gestational diabetes. It all adds up. And so we want to know that. And then the last thing is to speak up, speak up, speak up. Nikki mentioned to us, her sort of just amazing story of how she really took her symptoms seriously, even though she thought about, going home and maybe continuing to say, oh no, this is just GERD, this is just acid reflux, I'm too young. I see so many women in my office, in the hospital, in the ER when I go to see them. Their symptoms of a heart attack is not chest pain. They're nauseous. They're like, Dr. Eliazu, I feel weak. I can't cook the 10 meals I've been cooking, every Sunday for X amount of years. They're incredibly tired. It's not chest pain. They sometimes have jaw pain. They're more short of breath. These are things that I see in my women as opposed to my men who come in and they're like, I feel like there's an elephant sitting on my chest. I rarely hear that classically from my women patients. And so I want you to speak up, to take it very seriously. If you're having these symptoms, tell your physicians, and so we can do tests. And like Nikki was saying, we can start with tests that kind of lead us down the direction. We can start with a coronary calcium scan and then go from there. But ultimately, we want to catch the heart disease if it's there early. And so those are my big points. Happy to take any questions. And again, thank you so much for allowing me to be here today.
Thank you so much, Dr. Eliazu. That was very important information and I think applicable for those who are already in perimenopause, postmenopause, or even for some of our college age students. I had a couple of follow-up questions for you, and these are from our audience members. So first, what is considered a normal weight? Is this based on BMI?
Great question. So, BMI is traditionally gets a bad rep. And until we sort of figure out another way to sort of classify individuals on a standardized approach, um, BMI is unfortunately going to be what we have for some years to come. And so traditionally how we look at BMI is we classify people with a normal BMI, and then we say those who are overweight and those who are, obese and then morbidly obese. If your BMI is generally under 30, I would say you're in pretty good shape. The thing that we look at to sort of stratify that a little bit more, if I'll talk from a cardiology perspective, is where are you holding some of that extra weight? As I was mentioning, visceral fat located in the belly area is more inflammatory. And that's why, as cardiologists, we really look at waist circumference and some of these things that other physicians aren't used to sort of classifying, because that's where a lot of the inflammatory weight is. And I also look at how much of this sort of weight is muscle weight. Obviously, that weight is more metabolically active. Muscle, if you have more muscle in your body, it can help with other things, including blood regulation. And so I encourage my patients to get in the gym, to build up that muscle, to increase their protein, because that's kind of good weight, so to speak. But weight is such a tricky thing, and BMI is sort of all we have. But I encourage you all not to just focus on that number on the scale.
Thank you for that insight. Can you talk a little bit about the belly part of it, the menopausal belly? Are there more specific dietary changes that can help with that specifically?
Yeah, the menopausal belly, the belly for as a woman in general, it's just hard. And I think it's something that we don't give ourselves enough grace for in terms of our bodies and all that it does for us, especially post-pregnancy. So I think the first part is giving yourself grace, understanding that fitness is also a journey as well. And like I said, I think focusing on weight-bearing activity, I think really helps. A lot of people, traditionally think that when they go to the gym, they have to be doing this intense cardio, be running on the treadmill. But when I see my patients who are not as active and are trying to lose that sort of stubborn belly fat, I start with the basics. So start walking, first of all. We're never going to get to 150 minutes of moderate to vigorous activity if you think you're going to go from 0 to 100. So let's start walking. Let's do 30 minutes of just a slow walk, over a week. So you can break that up into 10 minutes every day or whatever you want, but let's start with 30. Let's bump it up to an hour, and then let's keep going from there. So weight-bearing activity is something that I like to really recommend, and then walking does a lot more than people realize. So walking.
Excellent. And that's something that most of us are able to do. And I like how you put in just practical points. You don't have to go right to 150, but start small, build your way up. One of our audience members said, "Thank you so much for your informative presentation. It reminds me of pregnant moms on my team that I work with. Many of them have gestational hypertension, and so we're sensitive to ensuring that they have blood pressure cuffs to monitor their blood pressure on or between visits." So I have two questions to follow up on that. The first, do you have suggestions for home medical devices that we should have to check on ourselves more consistently?
Yeah, great question. So, what I always tell my patients is whatever is affordable, whatever we can get that works, as long as it works appropriately, I'm fine with that. So actually, oftentimes in the office, I'll look on Amazon with my patients and we'll find a blood pressure cuff that works for them. I like the blood pressure cuffs that go on the arm versus the one that go on the wrist because they're a little bit more accurate. And then even bigger than the cuff that you have is how are you taking your blood pressure, right? So let's kind of discuss that for a brief second. So you're sitting down at the table, you're going to take your blood pressure, you're putting your arm in the cuff, your both feet on the floor. Your hands should be sort of leveled, down. They should be resting on something, and they should be no higher than heart level. The arm that you're checking your blood pressure in. I tell my patients, go to your happy place. We see a lot of white coat hypertension in the office, but that can follow you at home if you're so stressed out every time you take your blood pressure. So relax. Picture yourself on the beach. Try to make it, try to take your blood pressure after you've, done something fun or done something kind of more in line with self-care for yourself, and then record it and forget about it. And then do it again in a few days, and kind of bring that list with you when you go to your doctor to kind of show them your trend. But I think more important than what the actual device is how you're taking the blood pressure. And really any device, to be honest with you, Amazon, Walmart, wherever you have it is going to be fine as long as it works correctly and as long as you are taking your blood pressure the way you should. Legs uncrossed. I think I mentioned that they should be on the floor, but they should be uncrossed. You'd be surprised how many times that adds, 5 to 10 millimeters of mercury to the blood pressure.
Excellent. So, my last question before we move on to our last speaker, there was another question about kind of our younger patients. And one thing that I'm wondering is how they can advocate for themselves to see a cardiologist. Maybe they are having atypical symptoms for heart attack, or potentially they had preeclampsia. We had someone who mentioned having preeclampsia even 6 months postpartum, but then being told they were too young to see a cardiologist. So, what tips do you have for them?
Yeah, absolutely. So I'll say two things. I think the first is that with the rise of sort of awareness about how these pregnancy outcomes can affect future cardiovascular disease risk, we are having more practitioners, more cardiologists that recognize the need to see these patients earlier, to see you all earlier. And I, being one of those cardiologists located here at Grady, I'm always happy to accept referrals for these cases because they're so important. And like I said, if we can start early, we can get ahead of some of the heart disease. I think the other piece is that as that kind of knowledge gap closes and people are more aware of how pregnancy-related outcomes can affect cardiovascular disease, it's all about how much you advocate for yourself. There are some buzzwords, I think, as physicians that if you say, hey, listen, I had these adverse pregnancy outcomes. I also have a family history, or I also have been having these symptoms, um, of chest pain, of shortness of breath, dyspnea on exertion, all these things that make it more likely that your physician will, you know, if not send you to the cardiologist at first, order the appropriate test. So some of those tests, as Nikki mentioned in her story, an EKG, right? If the EKG is stone cold normal, then we can all take a little bit of a sigh of relief. Or an echocardiogram, which is an ultrasound of the heart, or a lab test that I use a lot in my postpartum patients called the BNP, which is a brain natriuretic peptide, that tells me if I should be concerned of extra fluid in your body and increased pressure in the heart, which kind of clues me into if we might be dealing with some pregnancy-related heart failure. So even if they're not sending you straight to the cardiologist, if they're ordering the right test, I'm happy, and I think we can all sort of take a sigh of relief, like I said, if those tests are normal.
Wonderful. Well, thank you so much. And we will now move on to Dr. Janella Burse, and she will bring us home with some information about hormones and the heart.
Hello, everybody. It's wonderful to see so many people on here. Thank you for my to my chapter for having me here. And thank you, Nikki, because I too was almost in tears, and I can't imagine what you went through. But can I ask Nikki one question before I start? And
Mhm.
that is, Dr. Ujioma just said about the EKG. Now, when you went to the urgent care, they said you had an abnormal EKG,
Yes.
right? So how was that lost later on? And when you went to the ER, your EKG was suddenly normal at that time, or what?
Well, they said that the EKG, it was slightly abnormal, but the cardiologist, took that moment to say that the urgent care is a waste of time and they don't know what they're talking about. So they totally dismissed it. They didn't even
Oh,
want to look at the EKG. They wouldn't even look at the EKG that the urgent care took.
wow. Wow. Okay. So another red flag for self-advocacy when,
Hmm.
yeah. So thank you. I'm sorry about the digression. Um, I'm a little bit more aggressive with hormone replacement therapy. Some of the things I have is a repeat, and repetition is important for learning. So it's going to solidify it in your head a little bit more. But I do have a little different opinions on hormone replacement therapy as also. And we've already talked about the menopausal effects on your heart, lipids, metabolic, blood vessels, and body. I will go to the next slide. I will delve into each one just a little bit more quickly because we have heard it, but should hear it again. As previously said, lipids are, when we say lipids, and I've slipped up and said that to people sometimes, they don't really know what I'm talking about when I say the word lipids, but lipids is your total cholesterol, your LDL, or the quote unquote bad cholesterol. Apolipoprotein B, you may start hearing about that. Sometimes that's a part of the LDL particle, and the HDL, which is the good cholesterol. And as you see, um, the arrows of too little of the good isn't good and too much of the bad is bad. And all of these, especially the apolipoprotein B, they're always trying to find ways to estimate our risk of heart disease, right? And our risk of atherosclerosis, or that hardening of the arteries that was previously mentioned. You can go to the next slide. So again, all of these fancy words up here is ways of
determining atherosclerosis and our risk of heart disease. Atherosclerosis is hardening of the arteries where you have to have the lipid imbalance and inflammation that was also mentioned. Inflammation is the foundation for chronic disease, all of it. Inflammation starts in the gut, so gut health is very important. That's a whole nother seminar, but gut health is very important, and inflammation is what is killing us. And inflammation, along with abnormal lipids, leads to plaque formation, atherosclerosis, and the hardening of the arteries, the narrowing of the vessels, the blood can't get through. Next slide. The metabolic changes, also previously mentioned, you might have heard the term metabolic syndrome. Metabolic syndrome includes your triglycerides being elevated, which is another form of lipid, your HDL being low. Again, we're back to that body fat mass, too much abdominal fat, which is toxic and inflammatory. Again, inflammation leads to, and cholesterol leads to atherosclerosis. Also, we have to look at our blood sugar. Metabolic syndrome is a part of that, and high blood pressure. So all of those make up metabolic syndrome, which increase our risk of stroke and cardiovascular disease. The body changes, increased fat mass, again, already discussed, decreased lean mass, and then you get that ratio. Obviously, if you have a fat-free mass, which is your fat-free mass is your muscle, again, a highly metabolic active tissue, it burns calories. So I know everybody likes when I say that in my office, muscle burns calories. And what's the difference? 5 pounds of muscle might look like this, 5 pounds of fat might look like this. So fat takes up much more volume. But we definitely want to have a increase in lean mass, muscle, bone, and a decrease in fat mass. Next slide. This summarizes a lot of what was said, especially all of these changes happen in menopause. And it's a direct corollary with our loss of estrogen. And we, Dr. Hill mentioned about, and Dr. Phillips about early menopause, less than 45, premature ovarian failure, less than 40. If you've had surgical menopause, meaning your ovaries were removed, and that term is oophorectomy. So just a little disclaimer about hysterectomy, the word total hysterectomy, we really don't use that medically to mean that your ovaries were removed. So I have to ask patients specifically when they say total hysterectomy, are you saying your ovaries were removed? Which most of the time they're not removed unless there's certain circumstances. But that surgical removal will put you into instant menopause because it is a function of our ovaries. And if you have a total hysterectomy with your ovaries removed or just your ovaries removed, which we will do sometimes in women with estrogen sensitive breast cancers, you are in instant menopause. And all of that will increase your risk of everything we just mentioned. So what can replacing your estradiol or estrogen do for you? So I'll use the term estrogen, although what our body naturally puts out is really estradiol. And a lot of this was mentioned, the vasomotor symptoms, the hot flashes, night sweats. The genital urinary syndrome was mentioned as far as the vaginal dryness, increased infections, leaking urine, the urinary incontinence, and that leads to painful intercourse as well. Also, you lose your bone density. And that's another very important cause of death with hip fractures. And a lot of people will die with that. And it's not just thin Caucasian women. The only reason one reason that is said is because we are really not tested like we should be for osteoporosis and osteopenia. I was shocked to find out that I had osteopenia. Totally shocked. Somebody who has worked out, done everything. So sometimes it's hard to fight genetics, but it'll be worse if you're not trying to do things to combat it as well. So that was a total shock to me. So I try to do extra things because of that. And also breast cancer. So this brings me to what the FDA has recently done in November. They are removing the black box warning off of all of estrogen products. They were removing it. Not the one about pregnancy, obviously, but the one about heart disease and breast cancer. They are removing that. And so we are slowly coming away from that fear that the WHI, or the Women's Health Initiative study, did in July of 2002. I remember it. And the NIH had this huge press conference that just totally obliterated the use of estrogen therapy. So again, women began suffering, and we also had increased risk of heart disease after that. So they did what they failed to mention in that press conference. They didn't mention any of the benefits of estrogen therapy, such as decreased risk of osteoporotic fractures, decreased risk of osteoporosis, decreased risk of colon cancer was also found. But so for the past 20 plus years, although they blasted it out on Time magazine, all the news, every news, whatever it had was, they were talking about no more estrogen, no more estrogen. Now, slowly over the last few years, they are dripping, drip, drip, drip information that is opposing that, but we are not hearing it. And we are letting that fear of hormones actually make us suffer and early death too. Next slide. So again, decrease what will estrogen do for you. Also, one thing I forgot to mention, the biggest thing about that study was they used pregnant horse mare urine for the estrogen, or Premarin. So those of us we've all heard of Premarin mostly, is pregnant mare urine. Horses have a lot of different estrogens in their bodies that we do not have. So they extrapolated the data from pregnant mare urine to all estrogen products, even the ones that we naturally make ourselves. So that was another flaw for that study, as well as the progestin they used was I don't want to say synthetic because everything is synthesized, but chemically altered from what we produce, progestin, which also caused a lot of the issues. But you have a decreased rate with estrogen, you have a decreased rate progression of atherosclerosis by 50% for some studies, and studies are ongoing. We try to practice evidence-based medicine, but that evidence changes. And there's so many studies, and so it can be confusing. And I know this may be confusing if I'm saying something different. But again, also the reduced risk of the whole lipid, now that we know lipid panel, decrease abdominal adiposity. So again, the fat mass around our belly. And I know this is a webinar for women, but the men too, when they get that andropause or that midlife crisis type picture, that belly fat around their belly, where did they get their estrogen? From conversion in their body of testosterone to estrogen. So when they have low testosterone, then they get low estrogen, and then they have increased risk of all of these things as well. And again, the FFM is the fat-free mass, and FM is free fat mass. So we also know we want more fat-free mass muscle than fat mass. Next slide. So again, I'm just reiterating, reduce our risk of death from coronary heart disease, reduce our risk of stroke, and reduce our risk of all-cause mortality. The sooner it is begun, this has been said before, the sooner hormone replacement is begun, the better. But we're slowly also getting away from that shortest time because we're focusing on the obvious symptoms of menopause or perimenopause, the hot flashes and the night sweats. And that does not go away for all women. I've had women come in their 80s still experiencing hot flashes and night sweats. So that's not the typical. So I'm not saying you have to look forward to 20, 30 years of night sweats and hot flashes, but some women do experience that. And definitely some more than the 3 to 5 years. And we also, again, need the right formulation. So not pregnant horse mare urine. Um, and we need, and this was mentioned before as well, individualized treatment. Talk to your doctor. And on the unfortunate part about talking to your doctor about hormones is we're not educated well on it. We never really have been. And then the WHI killed that even more. So a lot of us don't really understand it and fear it as well. We feared it just like everybody else. Next slide. And so I'm going to say something opposite that was previously said. Unfortunately, WHI study stopped another big study, a Danish study that was showing the preventive aspects of hormone replacement therapy. And had that study been allowed to continue, or if they had continued it, we would probably be saying something different here. But there are studies out there that really suggest that it is, from what we're saying, is if we get these problems more when we lose it, replacing it should be preventative. And it doesn't, if you think you've missed your time, that if you're over 60 and haven't started it, or it's been greater than 10 years since you've been through menopause, it's still not too late to start it. That doesn't mean that you cannot start hormone replacement therapy. And no, that's it. Thank you.
Well, thank you so much for that information. And I do think that it's important to highlight that even though we are all physicians, we all are going to have our own areas of expertise, lived experience, review of the literature, and that's why it's important to have an individual discussion with your own doctor and potentially get a second opinion if maybe you go to a physician, you're having night sweats, insomnia, all kind of things, and they're saying you don't need hormone replacement therapy. Well, maybe find a doctor who does do a lot of menopause and perimenopausal care, or somebody who has a NAM certification so that you can have your needs addressed. So we've had a couple of questions that have come up in the chat specific to menopause, and I'd love to ask you a few more of those questions. I know we're a little over time, so we'll try to be as efficient as possible. But can you talk a little bit about a time where we can feel like we are either in menopause or postmenopause? Is there a certain age that we can start to expect those feelings? And how long are we considered postmenopausal?
Um, Everybody's different, and sometimes I'm hesitant to put things out because then sometimes when we expect things, we might get them. But some women, as mentioned before, in their 30s, you just start not, sometimes it's just not feeling yourself. You might start having some night sweats, which usually come before the night sweats. We kind of lump hot flashes and night sweats all together, but night sweats are literally at night. Hot flashes are in the day, and it's not external heat. It comes from inside and it just emanates on out. Um, but everybody is different with that. But I've had patients, like I said, in their 30s, usually late 30s, just not feeling like themselves, brain fog, irritability, anxiety, depression, and especially if this hasn't been you in the past. So sometimes there are some behavioral or mental disorders that people may have, but usually not sudden like that. And we're busy, maybe busy with family and work, and we just ignore ourselves, which is what we've been talking about, and ignoring those subtle symptoms of perimenopause, menopause, a lot of us do. And sometimes it takes somebody outside to say, you're not really, just like you can see your partner changing, they may not notice it, and it can be the same for you. So as mentioned before, the average age of menopause is 51 and a half or so, no period for a year, but most people 5, 10 years before that are starting to have symptoms of the loss of their estrogen in their body. The term postmenopause to me, and just logically, and it's hard to really, you may see different definitions, but once you're menopausal, you're menopausal. So once you've not had a period for 12 months, and yes, you can go 11 and a half months and have a period, so you're not menopausal, unfortunately. But once you're not haven't had a period for 12 months, then you're menopausal. Then after that, you're just always menopausal.
Mhm.
And so some people will say that postmenopausal is once those symptoms stop. But then, like I said, for some women, that's never. And then what about the symptoms of vaginal dryness? That doesn't go away. So your hot flashes and night sweats may go away, but you will have vaginal dryness. And again, the genital urinary syndrome of the increased risk of infections, urinary tract, including urinary tract infections and leaking urine. So that time is forever.
Thank you. Yeah, I am in the same camp as you. I think of the perimenopause as that time frame leading up to menopause. 1 year without a period, you were menopause, and then there forward, you were forever postmenopausal. And then the same way as a young woman, when you have your period, some people have really bad PMS. There are some people who go through menopause and they have really bad symptoms, and then there are other people who have no symptoms at all. So I think that's a good segue. If somebody is in menopause and has not been having symptoms, is HRT still recommended?
I think that's really a discussion with you and your provider. But I go through a list. I have a list of about 20 symptoms of perimenopause and menopause because most people think, oh, I don't have any symptoms because I don't have any night sweats or hot flashes. But then when we start going through, is your libido the same? Are you a little bit more irritable than usual? And then sometimes, like again, are other people saying you're a little bit more irritable? Because some people say, I think I'm fine, but my such and such says otherwise. So anxiety, irritability, depression could be mild, just not feeling yourself. And one other one I forgot to mention, which can be tricky, is you have more of an awareness of your heart too. So then that scares us. And yes, we still should go see our primary and get a workup because we don't want to, you never want to assume that nothing's wrong. Assume that something could be wrong, find out that it's not, and then we can say, okay, well, then it's probably menopause. Because menopause, I don't know if anybody's experienced, you're laying down, you kind of hear your heart in your ear. You may feel a little flutter. Perimenopause and menopause can do that too. But please make sure it's not something else worse before we make that assumption.
Excellent. Well, I think our second to last question here will be for you, and then I do have one more question for Dr. Aliazu. For those patients who are one of those who have had a hysterectomy, how do they know whether or not they are in menopause since we're using that definition of 1 year without a period?
Excellent, excellent question, which highlights that it's a poor definition of menopause, right? Because there are also women using birth control that takes away their period. So whether you're on the Depo shot, some of the IUDs or the Nexplanon, you may not have a period. So it's really difficult for us to tell if somebody's going through menopause. There's a blood test called FSH, follicle stimulating hormone. It's not reliable, as Dr. Phillips said, because the levels wax and wane when we're in the perimenopause, especially when we're approaching menopause. If we get a result saying if we get a result that's low, meaning that you're not menopausal, then we know you're not menopausal because even if it goes up the next month, we know you're not menopausal because we have a result saying that you're not. But if you have one saying that you are menopausal, how do we know that we're catching you when you're high as opposed to low? So it is very difficult. A lot of us will get one value, and if it's showing that you're menopausal, maybe it's 6 months, and then a year get another one, and then we'll say, okay, well, you're 55, so you're probably menopausal or something like that. But it is a tricky situation, and one thing you don't have to worry about is pregnancy, and that's when it's a a real problem. We're like, do we stop the birth control or not? Um,
Right.
but as far as hormones, if you're having symptoms, we can definitely start some hormone replacement therapy for you.
Excellent. Well, thank you so much for sharing your insights. And if I didn't make it clear, Dr. Burse is definitely one of those physicians that would be happy to come and see you and chat with you about all of your hormone replacement needs. I know that there have been so many questions, and I apologize that we are not able to get to all of them, but I did want to have one more question for Dr. Aliazu, which is really twofold. One is for those that like to take energy drinks or even take in caffeine through coffee before a workout because they feel like it helps to get their heart going, do you have any insight into whether or not that's a good practice?
Yeah, that's a great question. And I think that's kind of been a hot topic in the media as well in terms of caffeine intake. So to put it kind of plainly, there's no kind of recommended amount of caffeine for every single individual. And this is where, and again, an individualized approach is really important. If you have any history of heart disease at all, similar to Nikki's experience, we definitely recommend cutting the caffeine levels. I also recommend, I think, depending on what kind of caffeine you're taking in, I think it's so important these days to kind of read the labels and try to see what exactly you're taking in some of these energy drinks. Some of them are incredibly packed with sugar, with additional amount of sugar. And that's not, at least some of them even have, you know, at least half of the daily value of sugar. And that's not something you should be consuming in one energy drink. So I think looking at the label, seeing what you're drinking, and then also looking at your symptoms. So, if you are somebody that drinks one cup of coffee and you are symptomatic, you're jumping off your seat, your heart is racing, you have to sit down and catch your breath, then that probably means that your body is not responding well to the caffeine. And so in those patients, I say, drop your caffeine levels, because if you are having palpitations and you're having skipped beats, we know that, everyone has skipped beats, but if you're having a significant number of skipped beats, that worries me. And so, like I said, it's not something that I can give a one size fits all prescription. All I can sort of say is that, really have it guided by your symptoms, but have it guided by your health status, your history of heart disease, if you're pregnant or not. I think that makes a difference, because, that recommended level is lower. And if you're sort of looking at the level, which I know most people aren't, and you're also not measuring when you're, making your coffee, and most times we're not the ones who are making our own coffee, but, we usually say around like 400 milligrams of caffeine, and that's about like 3 cups of coffee, a normal size of coffee, like a Starbucks tall sort of coffee cup, is what we recommend, as being the top level of caffeine that you should take in. Otherwise, watch your symptoms, watch your heart, try not to ingest as much sugar as is in these energy drinks, and try to keep it to a minimum, I think, whenever possible.
Wonderful. Well, as we wrap up here, I want to say thank you to Nikki for sharing her story, to Dr. Phillips for giving us information about the definitions of menopause, to Dr. Aliazu about the tips that we can use to recognize heart disease and prevent heart disease before it starts, and to Dr. Burse about hormone replacement therapy and reducing some of the fear and stigma behind it. I'd like to now bring on a couple of our sponsors to greet the audience. We'll start with the American Heart Association, actually, sorry, NCNW. We have Angelia Brown here.
Hi, good afternoon. NCW Greater Atlanta is so happy to partner in today's conversation. We hope that this conversation saves a life. Information is powerful, but action is the most powerful tool we have. So I hope that today's conversation spurs someone to go talk to your physician. Please get those tests. Go work, we're all talking at ourselves, right? And so we just thank you for allowing us to be a partner in this most powerful conversation. Thank you.
Thank you for being here and helping to sponsor and spread this word. We appreciate you. And last but certainly not least, we have the American Heart Association, Caitlin Cox.
Hi, everybody. Thank you so much for having me today. I just wanted to highlight a few things that I heard and during this conversation. And unfortunately, 55% of African Americans have high blood pressure. That means 1 in 2 people do. So knowing your numbers is extremely important. I saw that there was a question in the chat about home medical devices, and I wanted to highlight a program that the American Heart Association is doing here in Atlanta called Libraries with Heart, where you can actually go into one of your local libraries. There is a table set up where you can test your blood pressure, as well as renting out a blood pressure machine for 2 weeks, just like you would a book. We are in 5 different counties, 51 libraries. And I also wanted to highlight that your Chief Health Equity Officer, Dr. Wimberly, has begun a 2026 Heart Walk team on our website that I'll drop into the chat if anyone would like to join, walk with us in September, donate, as well as our American Heart Association website that has tons of resources, especially on women's heart health. And I'll also leave my email just in case anybody has any follow-up questions for me. But thank you so much for having me.
Thank you for being here, and we would love to sign up for that walk and take words and put them into action. So thank you. I see the link there. I also would like to elevate one of our Xi Alpha chapter sorors, Maya Lester. Are you available to come on camera?
It's not letting me turn my camera on.
Okay,
It
well, we
says
can
it's
hear
this.
you.
Okay, good afternoon, everyone, and happy Sunday. I am Maya Lester, and I serve as the Vice President of the Xi Alpha chapter of Delta Sigma Theta Sorority Incorporated. On behalf of my chapter, thank you so much for joining us for today's webinar. We truly appreciate your time and effort in engaging with us today, and we extend a sincere thank you to our panelists for sharing their knowledge and expertise with us today.
Thank you. It was so great to see many young women on the call as well. You are certainly at a turning point where you can make a lot of change in your life and really impact the future and help spread the word to your friends. So thank you for being here. And with that, this concludes Sisters in Red, Heart Health at Every Age. Thank you for all of our panelists. Thank you for our audience members for being engaged, for all of your insightful questions. We will be sure to send out a survey through our listserv so that you can give us feedback and move on, and hope that you're able to join our heart health team that was put in the chat here. Have a great one. And if the panelists could stay on for just a moment for a wrap up. All right, we'll give everyone a few more minutes just to clear out.